So the objective of this video is to help reorient students to the pertinent musculoskeletal anatomy that you learned back in gross anatomy. Anatomy is a really solid foundation. It's powerful when you can use that tool to help understand what's going on with your patients. So we're going to try to correlate some gross anatomy, actually show you some surface anatomy on actual patients, and try to demonstrate some of the important functional anatomy that you need to know on physical examination. And this is something that's been requested by students. I think it's helpful for those students doing orthopedic surgery, but also emergency medicine, internal medicine, family medicine, pediatric, radiology. All right, so let's get into it.
So here's an evaluation of the knee joint itself. So you have some of the major bone structures nicely outlined here. Of course, the patella, which sits directly anteriorly, the tibia inferiorly, the femur. This is real basic stuff you should be familiar with. And the fibula. The thing about the fibula is, remember, the fibula is always lateral. It's always posterolateral. So if you're ever looking at like a CT scan, for instance, and you're not sure which side is medial and which is lateral, well, fibula is always on the lateral side. Okay, and this representation here kind of shows the joint very nicely. It kind of shows the capsule of the knee joint. So that's outlined in green here, and you can see that the capsule extends quite a bit proximally, right? And when you get patients with joint effusions, they frequently will fill up with intra-articular fluid, and you'll often see that collecting on a physical exam up in this area, in this so-called suprapatellar pouch. Okay, a couple of other important relationships to keep in mind here is that this is your joint line, or the so-called tibia femoral joint line, at least. It's about at this level, and you can see the patella, for the most part, sits just about proximal to the joint line. Okay, a couple of things. If you're going into the operating room with these cases, you'll notice that typical arthroscopy portals are usually placed right here and right here, so anterolateral and anteromedial, and occasionally you may have a portal up here as well. All right, so these are some of the major capsular structures. I'll kind of rotate around here so you can just get a little bit of a better look. Okay, and this is the posterior part of the joint capsule shown here in green. Okay, and those are sort of demonstrate the boundaries of where the joint capsule is and where you may get joint fluid in a patient who may have an effusion, for instance. So here we actually have some of those capsular structures removed, so we can see the bones a little bit more directly with the muscles and important tendons attached. So here you have a frontal view of the knee. A lot of the major tendon structures are shown here. So here we're looking at the lateral side, and here we're going posterior. Okay, and then we'll come around and look at the medial side here. Okay, so let's go back anterior. So one of the most important anterior structures is going to be your Quadriceps Tendon. Okay, so your patella is right here again, and your extensor mechanism, or what essentially extends your knee, is that quadriceps mechanism inserting on the patella through the Quadriceps Tendon. Okay, and let's just get recentered here. Here you have your Infrapatellar Tendon. Okay, I'm sorry. Come back here. Infrapatellar Tendon, also known as the patellar ligament that goes between the Tibial Tubercle and the patella itself. All right, so that's just a continuation of the extensor mechanism. Okay, now while we're here on the lateral side, and again, we're on the lateral side, your fibula is right there. Okay, and one of the important lateral structures is your Iliotibial Band. All right, the Iliotibial Band. I'm going to zoom out a little bit here so you can get a good sense that the Iliotibial Band comes all the way down the lateral side of the thigh. Okay, and you can see it comes up to the pelvis, in fact. But in the knee, it can become clinically relevant because some people can get iliotibial band friction syndrome that occurs right where the iliotibial band comes past this lateral epicondyle. It's an important bony landmark on your physical exam. All right. So other structures, let's come over on the medial side of the knee. And here you have the Pes Anserinus, right? So you have the sartorius, gracilis, and semitendinosus, okay? And let's just slide up a little bit here. That's our Pes Anserinus, okay? Those three tendons, and they all come onto this anteromedial part of the proximal tibia, okay? Coming a little bit more posteriorly is our semimembranosus. So it's technically not part of the Pes Anserine tendons and inserts pretty far posterior medial on the tibia. Okay, continuing posteriorly, let me slide this over. A couple of important structures that you should be aware of in the back of the knee are the gastroc muscles, right? Or the lateral and medial head of the gastrocnemius. Okay, now sitting in this vicinity is also your popliteal artery and vein, and this is not an area you'll see a lot of orthopedic surgeons dissecting in a whole lot. But keep in mind, the gastrocnemius muscle actually crosses the knee joint. Okay, so it's a little different than the soleus muscle. And in fact, when you flex the knee, as you can imagine, you relax this gastrocnemius insertion, right? Because this thing rolls this way. This insertion, or the origin, I should say, comes a little bit more distal, right? And that relaxes the gastrocnemius muscle. It becomes important when you are doing certain foot and ankle maneuvers. So let's zoom out here. All right, now coming across laterally again, here you have your biceps, right? So long head of the biceps and short head of the biceps. But the biceps femoris essentially inserts here onto the fibula, and it inserts very close to where you have the fibular collateral ligament, or the LCL, or lateral collateral ligament. So it's part of that lateral soft tissue structure of the knee, the biceps femoris tendon. So your hamstrings are your biceps in the back here, and then your pes, in the back on the lateral side, and the pes on the medial side. All right, and those are some of your major structures that cross the knee joint that you should be aware of. I mean, in the vicinity here as well, but not really crossing the knee joint, are your tibialis anterior and your EDL muscles. And sometimes when we're working around the knee or doing surgery around the knee, you may see us have to deal with this muscle group here. But we'll stop there. All right, let's take a posterior view of the knee, looking at some of the deeper structures. Here we now have a very good look at the back of the knee joint. So again, femur, tibia, fibula, okay? Here you've got the posterior femoral condyles, right? So if we look at how the knee is situated, you can imagine the posterior part of the femoral condyle here is going to articulate when the knee is in flexion, right? So you can see with the knee here in full extension, that articular surface is kind of just sitting back there. All right. Some of the other important structures you need to know include the posterior cruciate ligament. So this is one of the intra-articular ligaments in the knee. And it's very important to look at how the course of the ligament is or how the ligament courses through the knee joint. And actually you don't get a great look at it here, but importantly, you can see how it inserts on the posterior part of the proximal tibia, right? And then it's going to insert on the femur more anteriorly. And the posterior cruciate ligament prevents posterior translation of the tibia on the femur. So it prevents the tibia from going out this way, okay? What else? Let's take a look at the medial meniscus. So here you can see the posterior horn of the medial meniscus, a part that's torn very frequently. And here we've got our lateral meniscus. You can see the lateral meniscus on the other side of the knee over there. Okay, lateral meniscus. And then we've got some of our extra-articular ligaments. Okay, so here you've got the lateral collateral, otherwise known as the fibular collateral ligament. You can see that it inserts on the femur, okay, at the level of the lateral epicondyle, and it comes onto the fibular head. So it actually doesn't insert on the tibia. It goes from the femur to the fibula, or the fibular collateral ligament, as opposed to the tibial collateral ligament, or the MCL. Okay, so that was the ACL. This is the MCL. So the MCL is the medial collateral ligament, and then it has a superficial and a deep structure. Okay, the medial collateral ligament, let's bring it into an anterior or frontal view, is going to prevent valgus stress. So if a force comes from the lateral side of the knee and tries to bust this open, this is what is going to prevent the knee from popping open on the medial side. The lateral collateral ligament is one of the structures that prevents, let's rotate back over, prevents varus instability. So if you were to get struck from the medial side, this is the check rein to prevent that. Okay, so lateral collateral, medial collateral. You got a good look at the meniscus there. The ACL isn't perfectly well seen here. So what you can see is the insertion on the femur is posterior on the femur. And here you can see it sits on this lateral side of the intercondylar notch. All right, you can kind of see this intercondylar notch here from the posterior view. There's where the ACL sits. When you do ACL reconstructive surgery, that's what you're going to be kind of looking at, although you're going to be looking at it from this view. And I'm going to rotate up here, and here's that ACL here. So it inserts anteriorly on the tibia, then goes up into the intercondylar notch and sits posterior in the femur. And the patella is kind of blocking our view here. Section here, as you can see, the distal femur is kind of been sliced away. So now let's get a good look at the ACL. Okay, so the ACL, you can see, starts again posterior on the lateral side of the intercondylar notch in the femur. Okay, kind of comes across obliquely, but most importantly goes from posterior to anterior. Now it doesn't necessarily have this wavy pattern, and there are a couple of bundles that make up the ACL, but this is the most important thing. It goes from posterior on the femur to anterior on the tibia. Okay, and it prevents that anterior translation of the tibia on the femur. And let's look at the posterior cruciate ligament. So here's the posterior cruciate ligament in green. All right, so the posterior cruciate ligament again inserts on the posterior part of the femur. Unfortunately, this is the insertion is on the femur is cut away because we cut away part of the femur. But it comes and inserts anteriorly on the femur in the intercondylar notch. Okay, so just you get the idea, hopefully, that it's coming forward. It just got cut away by the in this photo here. All right, so those are a couple of the major structures you need to know about ACL and PCL demonstrated here. Okay, one thing you should be aware of in the knee, as well as really anywhere in orthopedics, especially if you're doing surgery, are where are the nerves. Okay, especially in surgery. So here's a frontal view of the knee. This is the medial side here. Let's go right over to the posterior side and posterolateral side, because that's where some of the really important structures are. So we're going to slide this over. Come on, slide over. All right. So here we're posterior, and we're going to hide the long head of the biceps, all right? Because what sits right behind the long head of the biceps is the common peroneal nerve. And up here you can see you have the sciatic nerve, and that splits into the tibia nerve, or tibial nerve, which is going to come straight down posteriorly, and then the peroneal nerve, or common fibular nerve, or I should say common peroneal nerve. That's the term we usually use in clinical practice. I believe the anatomists use the term fibular nerve. But again, this sat right behind the biceps femoris, and I'm going to rotate around, and you're going to see that, I'm going to zoom out a little bit, the nerve courses behind the posterolateral part of the knee, and then if we come up here, you can see that that's the rest of the biceps. You can see that the nerve comes around the fibular head. All right, so this is the fibular head here. So this is an important landmark. common peroneal nerve posterolaterally coming around the fibular neck, okay, and then it splits into this deep peroneal nerve, okay, and then the superficial peroneal nerve, which goes all the way down to the foot. But the main thing to keep in mind is peroneal nerve splitting from the sciatic nerve from, with the common peroneal, and then the deep and superficial here. Okay, and that's on the lateral side, the posterolateral side of the knee, actually. Okay, so that's your major nerve structure you need to be aware of. Again, the tibia nerve is direct posteriorly, doesn't come into play quite as much. And here you can see this is the saphenous nerve, and one of the branches, sensory branch, you should be aware of when incisions are made in the front of the knee is the infrapatellar branch of the saphenous nerve. Okay, and it's important to keep in mind that that nerve comes from medial to lateral. Okay, they come this way. So anytime we make incisions in the front of the knee, where do they get numb? Well, they get numb on this side, right? Because everything medial to that cut is going to be okay, all right? But because the nerve is coming medial to lateral, everything lateral to the cut has been transected, and so a lot of times anterior knee incisions, they get a little bit numb, sort of on this lateral part of the knee, sometimes a little bit proximal, okay? So let's look at some knee surface anatomy here. So a couple of bony prominences you should be aware of. One is the patella, right? So the kneecap or patella, it's very palpable. It's right in front of the knee. If we extend the knee, one of the important things to recognize and how to just relax a little bit as much as you can is that the patella is pretty mobile, okay? So that's one thing you have to keep in mind. Patellar instability is something some of your patients might have. So recognize that there's a reasonable amount of medial to lateral motion, and that could be normal or pathologic. Let's flex up again. So another important bony landmark is your tibial tubercle, okay, and that's going to be right here, and that's part of the insertion of your extensor mechanism. So again, the quadriceps muscle inserts onto the patella, and there's a quadriceps tendon that's here that if you have a tear, you could palpate a defect here. Literally, your finger will sink in at this level. And the quadriceps goes on to the patella and then becomes the patellar ligament or patellar tendon. And I can, again, palpate here. I can feel that there's actually rolling over the tendon. Okay, so with the knee flexed like this, it should put the tendon under a little bit of stretch. You can feel it. If there's a tear here, again, you'll feel it'll sink in here, and that inserts onto the tibial tubercle. All right. So a couple of other bony landmarks to keep in mind are the fibular head. So the fibular head sits a little bit posterolateral. So we're on the lateral side of the knee here, and you should be able to feel a bony prominence here. Okay, it's lateral, a little bit posterior. It's the fibular head. Okay, a couple of important things to remember about the fibular head is that just below it is the fibular neck, and the common peroneal tendon comes in along the course of my finger here and runs along the surface of the fibular neck before it splits. And we'll show that in the other anatomy videos. A couple of other bony landmarks are the Gerdy's tubercle. So I'm going to come back to my tibial tubercle here. And then Gerdy's tubercle is a prominence on the anterolateral tibia. And just below that is not a bony landmark, but the muscles of the anterior compartment. Another bony landmark is the lateral epicondyle of the femur, okay, and that's right about here. So here's my patella, tibial tubercle, fibular head, and this is my lateral epicondyle. And something you need to be aware of is the iliotibial band. So the iliotibial band is a long band we showed in the showing one of the other videos. I can kind of feel the posterior edge here and the anterior edge right about here. And that comes this way. It goes right over the lateral epicondyle, and then it comes right onto the tibia at Gerdy's tubercle. So that's sort of can be a structure that might feel a little bit tight in some patients. Other landmarks would be the medial epicondyle of the femur. Okay, it's not a very sharp prominence, but it is a prominence nonetheless. And Then with the knee flex, one of the things we want to try to assess is the joint line, or the tibiofemoral joint line. And you should be able to feel that as sort of almost like a sulcus from on the tibia here, and I drop down and then I hit another bony prominences and roll up. I'm in that joint line. So whenever you're seeing arthroscopy being done, the knee may be flexed up to 90 degrees. You'll see they'll feel the inferior pole of the patella, where the sort of side of my thumb is there, and then the joint line kind of is roughly in that same spot. So if you come just below the inferior pole of the patella and then come over, I got the tendon on either side, and this is where that soft spot you make your arthroscopy portal. Same thing on the other side. At the level of the joint line, right next to the tendon, and you drop in. And that's how you get into the joint when you do arthroscopy. So let's talk about ligaments. So the ligaments aren't that easily palpable. Now for the lateral collateral ligament, which goes between the fibular head and the lateral distal femur, you often have to do what's called a figure 4 position. So you can see what I'm doing is we're allowing the hip to abduct. We're almost like you're crossing your legs over. And then what I'll do is I'll try to I'm feeling the fibular head, and then I'm trying to feel a band running this way, okay, between the fibula and the lateral epicondyle in that vicinity, and that's the LCL. And it's a bit of a band. You should be able to feel it when you stress it in this position. All right. The MCL is on the medial side of the knee. It's going to be a little bit more difficult to sort of palpate as a discrete structure, but it's going to run between the medial distal femur and the tibia in this direction. These are both extra-articular ligaments. Let's pause there. So the cruciate ligaments are not something you can palpate very easily. They're intra-articular ligaments. So ligaments, of course, connect bone to bone, right? So the LCL connects the fibula to the femur. The MCL connects the tibia to the femur. And we'll go through some stress exam shortly to show what we do with those ligaments if we suspect they're injured. The ACL and PCL are intra-articular. So remember, the ACL prevents anterior translation of the tibia on the femur, okay? And the PCL, which is oriented this way, as opposed to the ACL, which is oriented this way, the PCL prevents posterior translation of the tibia. We show this in the other videos, but let's just kind of show how we examine that. So the one way to examine the ACL, the so-called anterior drawer test, I'm going to palpate where the joint line is with my thumbs, and I'm going to try to basically pull the tibia forward, and I'm feeling that translate with my thumbs and seeing how much that moves. The posterior drawer test is basically the opposite, where I'm going to push the tibia posteriorly and again feel my thumbs if the tibia is translating, and this is a negative exam. So why don't you lie down, and we're going to try to have the patient relax as much as possible. So then Lockman Test, you're going to try to relax the knee as best as you can, and then you're going to grasp the femur with one hand, the tibia, again I'm having my thumb at the joint line, and then I'm going to try to bring the tibia forward. And if the patient's relaxed, you should be able to demonstrate if there's any motion, and his ACL doesn't move. Again, I'm trying to bring the tibia anteriorly and see if that ACL is loose. Important tendons, I already talked about the quadriceps tendon. So we said that if you're in the flexed position, it should bring this under tension as well as here, and you can often palpate the tendon, and if it's ruptured, you can palpate a defect. One thing you can ask the patient to do if you suspect an injury is to utilize their quadriceps muscle and try to do what we call a straight leg raise. So why don't you try to lift your foot off the table, and you can see that the quadriceps muscle is contracting. I can now palpate the tendon is under tension, as well as the patellar ligament or patellar tendon down here. And if the patient can lift the leg up, you would have to expect that the extensor mechanism is intact and you don't have a tendon rupture or a displaced patella fracture. So to check the lateral and medial collateral ligaments, one thing we do is a stress exam. So if you remember what they are trying to do, you now try to see if they're really working, right? So for the MCL, I'm going to flex the knee slightly, and then what we're going to do is we're going to do what's called a valgus stress. So I'm going to try to open up that inside part of the knee. So I'm going to flex the knee slightly, one hand on the lateral side of the knee, and I'm going to I'm holding the medial side of the leg here, and I'm going to pull it over. So I'm pushing with one hand, pushing with the other hand like that, and I'm going to try to see if that medial side of the knee opens up. Again, a little bit of flexion. And then for the lateral side, I'm going to do a varus stress, so opposite. Now my hand's out here. My right hand in this case is over here. I'm going to have the patient relax a little bit, and then I'm going to try to do a varus stress. And then you repeat this and compare to the contralateral knee. And you see how much motion there is, indicating if that ligament is torn. So hopefully our objectives were met. For those of you interested, the computer anatomy software you saw is called Complete Anatomy 2018 by 4Medical. Hope you enjoyed the video. Thanks. Bye.